Yeah, we're recording this meeting, which is great. I was just putting in the chat that I need a recording of that introduction, though, to be able to play back to myself at some point. That was great. My 3-year-old and my 6-year-old don't care too much about some of those accolades, but I mean, my mentor Sachin Ketapal has told me, yeah, don't worry, your family doesn't need to read your resume. So anyhow, again, I am honored to be here, honored to be talking to this group, and we'll be pondering when I'm going to be making the trip down to the Cayman Islands with my family for this in person. But the next best thing, I guess, is having this Cayman Islands virtual background and being able to talk virtually. So thanks again for those who've joined this evening. I'll be speaking about AI and machine learning and the practice of anesthesiology. John gave a great introduction already. As far as conflicts of interest, I have research funding through the NIH paid to my institution, but I don't have any personal conflicts of interest with any vendor. With that, I'm just going to get started. So just a quick overview of what we'll be talking about today. I'm going to first give just a bit of background and context. There's a number of different data science terms that can be recently thrown around somewhat haphazardly, and it's helpful to have some clear definitions of what we're talking about. And just real quick too, is my screen sharing doing well and my audio okay?
Yes.
Okay, perfect. So we'll be talking about some definitions, and we'll be motivating why AI and machine learning is a more important topic than ever before in healthcare, and why clinicians, including practicing anesthesiologists, should care about this. After establishing this problem space, we'll talk about some real examples, either current or near future examples of machine learning and AI applied to anesthesiology. And then for each example, I don't want to go into the weeds about each study. I do suggest to those who are interested in these studies that I present that you can read further about them. But I instead want to use these examples as a way to illustrate a few critically important dilemmas in machine learning applied to healthcare that all clinicians can become acquainted with. And then by the end of this talk, I hope that I've brought to the forefront ways that we can all apply machine learning derived inferences appropriately and mitigate against some of the challenges they might present in their application to healthcare. So let's just as a warm up, we'll just jump right into our first Zoom poll question for the audience, just to get a sense of where everyone stands in terms of machine learning and AI in healthcare. So we can put that poll question up right now. You'll see it here. I'll just read the question off. Over the next decade, to what extent do you think that AI will change day-to-day anesthesiology clinical practice? And that could range from completely revolutionize our practice. In fact, it becomes a standard of care substantially, meaning it has many uses and the average anesthesiologist should be trained to use it, but may not be standard of care yet. Or a little bit less, modestly, maybe there's some uses and some appreciable impact on day-to-day practice. Maybe minimally, where there's just a few new uses with limited appreciable impact, or not at all, meaning it's just the same as we're experiencing right now today. I guess no change. I mean, there is some AI and machine learning already applied to anesthesiology that we'll talk about in a second, but in a decade, do you think we'll have made progress? So as I'm looking at the poll numbers come in, we have looks like a somewhat progressive audience thinking about and this may be optimism or pessimism. I don't know, but we at least are thinking progressively, and it seems like the majority of the responses are around the substantially level. So perhaps there will be many uses, and the average anesthesiologist will be expected to be able to interpret and implement. Great, I'm going to end that poll. So we'll just jump right into some background and context. So just before we get too far, what are we even talking about with AI? There are different levels of complexity here, and it's helpful to get an understanding of where we're at in the world today in terms of the level of complexity of AI and what's actually penetrating healthcare. So you can think about this as in terms of 4 levels of complexity. The simplest level is reactive AI. These are AI systems that have no memory and are very task specific. An example of that is Deep Blue, the IBM chess program that was able to beat Garry Kasparov in the 1990s. A step up from that is a type of AI known as limited memory. These are systems that have memory. They can use past experiences to inform future decisions. Some of the decision-making functions in self-driving cars are designed in this way. And there are several weaknesses to this type of AI, which we'll highlight in this talk. The next highest level is a level of complexity known as theory of mind. This is a psychology term, and when applied to AI, it means that the system would have the social intelligence to understand the way in which humans think, to understand emotions, and would be able to infer human intentions and predict behavior, a necessary skill for AI systems to become integrated into human teams. And then the highest level is this notion of self-awareness, where AI systems actually have a sense of self, which gives them quote unquote consciousness, and they would have the ability to have human level intelligence that could bypass their own intelligence. And to be clear, where we're at in the world today is this type 2. We're talking about limited memory with many different weaknesses and issues that we need to think about if we're going to apply this meaningfully and safely in healthcare. So that's where we're at in the world today is this type of AI. What's the goal here? It's also helpful to reiterate that physicians will always have a place in medicine. Machine learning algorithms are great tools, but they're no substitute for the judgment, the intuition, the care of a thoughtful clinician who understands the full context and impact of their clinical decision-making. They may be able to implement machine learning algorithms and use them as tools to guide their clinical decisions, but they will fully appreciate the impact of their clinical decision-making and understand the implications of treatment administered to patients. So there's, kind of another way to think about this is there's strengths and weaknesses that humans and machine learners or algorithms can offer. On, from the perspective of a machine learning algorithm, you can get rapid predictions, accurate if the data that they are trained upon is accurate, and they can be quote unquote unbiased. I put that in quotes simply because if machine learning algorithms are trained to replicate human behaviors and humans have biases, the algorithms will reflect those biases back at us. And I will talk about that in this talk. The drawbacks of machine learning algorithms, again, are the lack of transparency, the lack of appreciation of the impact of the treatments. So they lack a clinical judgment that comes with taking care of tens of thousands of patients, as we all have in the course of our career. On the converse, humans are the opposite of this. We understand the implications of our clinical decisions. We understand through caring for tens of thousands of patients over our career what the consequences of the treatments that we administer to patients. But we are expensive and we are slow compared to a machine learning algorithm in processing multiple data streams simultaneously. So there's a trade-off here. Why should we care? I want to again offer a contrarian view here. Why does this even matter? And what I would say is that changes induced by machine learning and AI are disrupting every industry. Healthcare isn't any different, and these changes are coming. The best thing that we can do is prepare for them. So just like interpreting, trusting, or applying a study in anesthesiology, published in Anesthesiology, that demands a reader to have a basic literacy in statistics and study design, interpreting, trusting, and applying technologies using AI and machine learning demand a basic literacy in machine learning methods. Why is it so hard to reach healthcare applications? Unlike other industries that have done well to integrate AI algorithms into their workflow, healthcare has been challenging. I would offer a few reasons why this has been challenging. Number one is that mistakes really matter. So if, for example, Facebook misclassifies your face as your twin brothers, that's annoying, but it's not dangerous. Another issue is that our culture is just less accepting of computer errors. So, for example, a Google self-driving car, for that to be accepted, it wouldn't have to be just better than a human. It would have to be nearly perfect. Another issue is that being right isn't enough. Getting to the correct treatment or diagnosis just isn't enough. We need to understand the mechanism and be justified in our decision-making so that we can mitigate anticipate and mitigate against the next problem that a patient might have for which we may not have assistance from a machine learning algorithm. And then beyond these issues is just a fundamental limitation to data sharing in healthcare. There's the issue of PHI and navigating the data sharing of the protected health information. And there's also just the proprietary nature of machine learning algorithms. And finally, there's the issue of interoperability across healthcare platforms. So different health systems have different software vendors, document things in different ways. And so this issue of data sharing is very challenging in healthcare. So with that overview, I'm going to jump into the meat of this talk now and highlight just some real examples of machine learning and AI applied to anesthesiology that we can bite into. And for each example, use this example to highlight logistical, social, and ethical dilemmas that may arise with implementation of AI and machine learning in healthcare and how these issues can be mitigated. So with that, I'll jump to the next Zoom poll question, which is, what makes you anxious about AI in anesthesiology? And I have a couple different choices. There may be others on this that aren't on this list, but I'd love to hear just from the audience. You know, there are plenty of potential benefits of AI, but there's also a lot of drawbacks. There's the issue of transparency, of explainability. There's the issue of when something goes wrong, who's to blame? What are the medical legal implications of errors? There's this issue of autonomy and job security. Do we think that everything about our job is going to be threatened by an AI algorithm? There's the issue of threats to patient privacy, the issue of needing additional training, and there's the issue of accentuating biases and inequities in healthcare and how algorithms might exaggerate that. I'll just pause for another 10 seconds. Good blend on this one. It seems like a range of different concerns across these. But are you able to share the results? Oh yeah, of the poll there, Mike? Sorry. I'm gonna
you know what? Can we wait until, I'm sorry, Tracy jumping in. Hi, everybody.
No problem.
I wanted to get to like a 75% threshold and
then.
Yeah,
but we're at a minute now. So
share.
Yeah.
Huh?
Yeah, it's a minute now, so we can go ahead and show the results.
I'm gonna hit end poll, or there we go. We can share the results. Great. So this one has more of an even blend of different concerns, and I think these are all valid concerns that we need to think about. I don't want to discredit any of them, but we just need to take a balanced approach. There are benefits to AI and machine learning applied to anesthesiology. There are challenges that we need to think about and mitigate against. So interesting to see the wide range of different sources of anxiety here. So we'll jump into this first example, that being an article published in 2018, that's now 5 years ago, in Anesthesiology, dealing with a machine learning algorithm to predict hypotension based on A-line waveform analyses. And you may be familiar with this, but the goal of this study was to use an A-line waveform to predict hypotension 10 minutes prior to the event actually happening. The data set being used was an ICU and operating room data set across multiple centers, which is an important characteristic of training and validating a machine learning algorithm. If it works at one healthcare center, that's one thing. If it works across multiple centers, that's an advantage for. But really, I get into is actually just how what the study breaks down is just how much of an untapped resource an A-line can be. We know that there are obvious bits of information in an A-line like the systolic blood pressure, the MAP, diastolic blood pressure, and the heart rate. We recognize that there are more complex things like the systolic pressure variation, the DPDT, the area under the waveform. But this is actually just the tip of the iceberg. This team developing this index was able to come up with over 3,000 characteristics of an A-line. And by using combinations of those features, was able to come up with millions of features to use in a prediction algorithm. This prediction algorithm was able to predict hypotension 10 minutes before the event with near perfect accuracy. And you can read more about the performance characteristics of the algorithm in the study. But to just illustrate one example patient, I just wanted to show this figure from the study, where on the top figure, we have the patient's blood pressure on the y-axis, and time on the x-axis, and you can see this patient either in the ICU or the OR, but slowly developing hypotension defined as a MAP less than 65. And you can see that not just 10 minutes before the event, but well before the event, this patient on the bottom figure had a hypotension prediction index of nearly 100. So this index on the bottom shows the probability that this patient would be having future hypotensive, again, a MAP less than 65. And so with high confidence, this patient was predicted to have hypotension well in advance of their hypotensive event. So there's certainly a interestingly high performance in this algorithm, but really in terms of a clinical application, the $1 million question is, can this actually prevent hypotension? And the $1 billion question is, can it actually improve outcomes? And it turns out, as some of us might know from either our own personal experience using these or through reading these articles, that the answer is not obvious. There were 2 publications last year, 1 or 2 years ago, one in JAMA, one in Anesthesiology, that yielded conflicting results. Now, these were small single-center studies, but the fact that they led to conflicting results does offer caution to the generalizability of this algorithm and its ability to have an effect on meaningful outcomes like preventing hypotension or reducing complications after surgery. Adding to this confusion has also been studies more recently in which the predictive ability of the hypotension prediction index was just directly compared to the patient's current mean arterial pressure. And the findings in a small preliminary study have shown that simply looking at a patient's MAP and seeing if it ever dipped below the 70 to 75 range was nearly as effective as predicting future hypotension defined as a MAP less than 65 compared to the hypotension prediction index. So this is a figure of a recently, I think a recent commentary in anesthesiology comparing on the top half of the figure, the blue line and the blue threshold being the hypotension prediction index and the threshold above which you have a high likelihood of having a hypotensive event, and the red line and the red, I guess the red tracing and the red lines are the mean arterial pressure of the patient and the thresholds upon which, if you got below, you would be likely to have a hypotensive event defined as a MAP less than 65. And so there's been a little bit of a kind of a swinging back of the pendulum. This with any new technology in applied to medicine, you may have this kind of, again, this kind of boom and bust cycle of having a very inflated expectation of the new technology. We've seen this in other, monitoring devices. The BIS monitor, for example, has had this similar boom and bust. You get through that, you have maybe what we might be headed towards right now with HPI is the trial of disillusionment. And then over time, we'll find that, like many other trials of practice patterns, monitors, and goal-directed therapies in medicine, the truth is probably somewhere in the middle, that it's not a useless thing, but it is, but it's not perfect. And if we know how to use it appropriately, we can effectively improve clinical care. I bring all this up, and the dilemma I want to talk about is the fact that we had 2 different studies that had conflicting results raises an important issue. Beyond simply doing a randomized controlled trial for every single algorithm in every conceivable healthcare setting, how can we enable machine learning algorithms guiding clinical decision-making to gain traction in real-world clinical care and not lead to major unintended harms? And this is where the FDA has recently stepped in and developed a framework for evaluating software, including machine learning algorithms, acting as a medical device. Now, I'm not going to get into the details of this framework, but the basic considerations that the FDA is making when products are coming to market, algorithms are being deployed in healthcare settings, is that, number one, is there a valid association between the algorithm and a clinical condition? Number 2, are the predictions accurate, reliable, and precise? And number 3, does this work in the real world? When we iteratively deploy it in a clinical setting, does it achieve its intended purpose? And to regulate exactly how fast some of these algorithms, the software using a machine learning algorithm acting as a medical device enters the real world, there was this recognition that the potential for harm hinged on two things. Number one, how significant the intervention was. So are we simply informing the clinician versus making a diagnosis or actually treating a condition? And certainly if you're treating a condition, that's more significant than just informing the clinician. And that's kind of on the x-axis of this table. And then on the y-axis is how serious the situation is. So are we optimizing an outpatient pain clinic schedule based on your patient's comorbidities coming into clinic, the weather patterns, the zip codes of the patients traveling into clinic? Are we trying to do something like that, or are we trying to predict sepsis? And certainly there's a range of seriousness to the situation that also guides exactly how aggressively we need to monitor device algorithms acting as medical devices. And so the FDA has developed this graded approach to regulating software, especially machine learning based software, as a medical device. And basically has this graded approach, and with each gradation, the performance bar, the effort to bring a product to market becomes substantially greater. Now, the FDA approved software as a medical device isn't the theoretical. This approval process is becoming more common. Here's a timeline showing a smattering of different algorithms across specialties. A few I just want to zoom in on that might be relevant to anesthesiology are displayed here, such as the detection of AFib, the diagnosis of acute intracranial hemorrhage, a chest X-ray analysis, so automating the detection of pathologic findings on a chest X-ray. All of these are FDA approved and potentially coming to a hospital or patient population near you. I'm going to shift gears now, and we're going to talk about another example of an algorithm applied to healthcare. This one is looking at a deterioration index, an index that predicts deterioration among hospitalized patients with COVID-19. So the goal of this algorithm was to use information routinely collected in an electronic health record to predict deterioration, defined as an ICU transfer, the need for mechanical ventilation, or death. It was a cohort of patients at the University of Michigan admitted to a non-ICU setting, and the data collected was, again, anything generally routinely available in the medical record: demographics, vital signs, nursing assessments, lab values routinely collected. The model output was a score 0 to 100, representing the likelihood of deterioration. And the algorithm performance was modest. So this AUC is certainly not perfect. It's not worthless either. It's somewhere in the middle. And beyond simply talking about if you're interested in more details around the performance characteristics of this model, I direct you to the study. But with my time here today, I want to talk through how does this work? Why should we trust the algorithm or not trust it? And in what situations? And beyond that, what should we do with this information? As it turns out, there's multiple considerations for a model to be trustworthy and useful to frontline clinicians such as anesthesiologists. At a minimum, the model has to be accurate, but this is only a starting point, and there's many different layers to address for a model to be trustworthy and useful to clinicians. So building up from this base layer of accuracy, a model needs to be transparent. That is, a clinician needs to understand what factors are driving a prediction model. Mechanisms are very important here. So just like the many causes of hypotension or hypoxia might imply different treatments, the same is true for a prediction model. Is it the patient's arterial lactate that's driving the prediction, or is it the patient's respiratory rate? Beyond transparency, a model needs to be credible. And that is to say, does the variable driving the prediction fall in line with expert opinion, or is it in contrast to decades of literature on a particular topic? Now, experts can be wrong, but that's uncommon. And for a model to be credible, it needs to be influenced by variables that offer plausible biologic mechanisms underpinning the relationship observed. So, for example, if a deterioration model largely hinged on a patient's age, vital signs, and a blood gas value, that's more credible than a model that seemed to be driven by the day of the week, the patient's height, the patient's serum chloride level. That's not to say that useful inferences can't be made based on the time of day, height, and chloride. I'm just saying that they tend to carry less weight than factors that an intensivist has come to trust through decades of established research and teaching. And then finally, at the pinnacle of all of this is whether a prediction model is actionable or at least informed by modifiable risk factors. So it's one thing if a risk model is built on a patient's age, comorbidities, and sex. It's another thing if the model is built on things that can be modified in real time, such as the patient's blood pressure, SpO2, hematocrit. And if you can have variables plausibly tied to interventions, then there's at least the potential to inform treatment decisions beyond just risk stratifying patients. So taking into account these principles of transparency, credibility, actionability, let's take a look at the Epic Deterioration Index. This is a fictional patient, and I have no conflicts of interest with Epic. There's no, but I find it a very useful point to illustrate how they have approached displaying information from an algorithm to clinicians. So not only so here what we see again is something that if you have Epic, you can actually embed this deterioration index and calculate it for your patients in your hospital. But let's take a look at how they approach this information, the probability of a patient deteriorating. So not only do the clinicians get a probability of the patient deteriorating, so again, this probability of needing to go to the ICU, needing mechanical ventilation or death, but they also get transparency into what characteristics are driving this machine learning model. You get some credibility into understanding how important these variables are to the model. So we see that it seems like the age, the respiratory rate, and the fact that we can't get a neuro exam on this patient, that seems to be the important driving factors for this high probability of the patient deteriorating. And finally, it embraces actionability by incorporating at least a few potentially modifiable risk factors. Now, this isn't a panacea, but by showing what's under the hood, the Epic Deterioration Index is worlds closer to earning a clinician's trust than just displaying the probability on the left-hand side, this seemingly magical black box risk score of 41.9%. But there's another issue here too that I want to just touch briefly on, which is in order to make machine learning in healthcare trustworthy, there's this issue of data set shift, which is broadly defined as an evolving mismatch between data that an algorithm is trained on versus data that it's tested on, which can lead to the underperformance of a machine learning algorithm. And I bring this up simply because many prediction indices, including the Epic Deterioration Index, were found to have a precipitous drop in performance during the black swan event of the COVID-19 pandemic, when the entire ICU looked dramatically different. In 2020, the makeup of the ICU in any hospital looked dramatically different from the previous year. And that led many institutions to have to rethink any prediction model that was being deployed in their healthcare system. And although COVID-19 is kind of a stark example, this issue of data set shift is happening all of the time. It can happen when the demographics and comorbidities of a patient population change over time. I mean, again, the COVID-19 pandemic was a dramatic shift, but this can happen slowly over time as well. It happens when there's a fundamental change in healthcare delivery too. So if we switch to a new software vendor, our healthcare system may document things differently, and that can lead to data set shift. You can have a changing definition of a disease. So if a consensus guidelines update the definitions of what is sepsis or what is chronic hypertension, that can lead to data set shifts. It can even happen if there's changing clinician incentives to documenting. So if the reimbursement for a particular diagnosis or quality measure changes, that might change how often a piece of electronic health data is documented, and that might actually change the performance of a prediction model. This has led many hospitals, including the University of Michigan, to start thinking about developing healthcare algorithm governance committees. There's a QR code to an article that talks about this, published in New England Journal of Medicine, where these clinical healthcare algorithm governance committees can actually turn on and off algorithms deployed in their hospital based on observations from frontline clinicians. So at the University of Michigan, we developed what was called the Clinical Intelligence Committee that had to turn off the Epic sepsis prediction model at the height of the COVID pandemic due to its poor performance, potentially incentivizing misguided clinical practice. So it's just an interesting concept that if we are really to achieve reliable implementation of prediction algorithms embedded at the point of care, you need to have this governance committee comprised of clinicians, data scientists, bioinformatics experts, even ethicists involved, and to have an extremely tight-knit, rapid, close-knit communication loop with frontline clinicians. So here's a QR code to an article that dives into this idea of governance committees, if you want to read more about that.
Michael, could you just go back, please, to the different clinical factors? Go back. The different clinical, here we go. So this is what I asked you earlier. So I look at this and say it's actionable. Okay, oxygen, that makes sense. Sure. The systolic is 130. I don't know, the patient's old and has cerebral vascular disease that needs to be higher, or that the heart's working too hard, it needs to be low. I mean, so I'm not sure, I don't know how you think about this, what should you do if you see this?
Yeah, and I think a lot of it, is, the answer is that it depends. It depends a lot on the clinical context. So this is a tool, and this may mean something very different to a clinician who is, for example, admitting a patient to the ED that has a type A dissection that needs to go for emergency surgery. And hey, yeah, the systolic blood pressure of 130, yeah, we need to lower that. We need to start an esmolol infusion. Versus a patient that's being admitted for pneumonia or a COPD exacerbation, where maybe we really don't care about that blood pressure. And so this is a tool. This is not, again, going to replace clinicians' judgment, but can help augment clinical decision making. The way I've actually seen this used in real time is not necessarily to guide clinical decision making heavily, but I have seen it applied to when you have an ICU patient census, or you have a census of patients in moderate care, and you have a limited amount of time on rounds to talk about your census of 25 patients. Which patients are the ones that you need to slow think versus which ones can you fast track and get to a less aggressively monitored setting. And so I've seen decisions made about which patients should stay in the ICU, which patients might be fast trackable and can get to the floor based on this algorithm. But I think that's one way to think about this is you can maybe budget your time to the patients that have a high deterioration index, or the patients that have moved substantially overnight. If you have a patient who had a deterioration index of 10%, and then overnight they jumped up to 40%. Well, what happened to that patient? Let's slow think this patient and figure out, is there something else that we that's tripping this algorithm that we can think about it and talk about on rounds. So again,
thanks a lot, Dr. Mathis. Yeah. So you got a low number. We can give you another room to supervise. Carry on. Thank you.
But I think, allocation of scarce healthcare resources. Anesthesiologists are a very valuable resource to their health system, and can really advance the safety, the patient safety mission. And so this is, I think, part of it is just distributing in a efficient and effective way scarce resources safely. So that's one way I would think about it. Great question, though. I'm really interested to think about other ways that you can use that algorithm. Another example, this is actually the final example I want to talk about today. And I think it's also the most controversial. It has the most interesting dilemmas involved in it, is an article published in Anesthesiology talking about predicting post-induction hypotension. So this published in 2018, again, 5 years ago. So this is not something that is brand new. It's been around. And it's this idea of using a machine learning algorithm to predict hypotension after the induction of general anesthesia. Similar to other prediction algorithms, it's taking information routinely collected in the healthcare and the EHR. This was a study of NYU surgical patients, teenagers and adults. And they collected data in your preoperative H&P, also some data from the patient when they hit the OR, but before the induction of anesthesia. So initial vital signs, some initial preoperative and intraoperative medications before you actually induced the patient. In this study, the best prediction model yielded modest performance in predicting hypotension 10 minutes prior to induction. So again, an AUC, as we know, an AUC of 1 is perfect, an AUC of 0.5 is worthless. So this is somewhere in the middle. And again, I just refer you to the article for details on the algorithm performance. But with my time here today, I want to talk about what we do with this information. And to the the point that Dr. Ellis raised earlier, the answer to that question is, like so many things in healthcare, it depends. It depends on the nuanced clinical context, and it also depends on the shared values of the anesthesiologist and the patient, which we can call judgment for purposes of machine learning modeling. So I just this slide is basically breaking down the anatomy of medical decision making, or really any decision being made. And on the left-hand side of this figure, we have data that is used by a machine learning model to make a prediction. So that's what a clinician needs to know in order to understand what will happen next. And in the middle of this, and often overlooked, is this concept of judgment. And this is used by a clinician or machine learning algorithm to value different outcomes differently. So this is what a clinician needs to know in order to take action, to administer a treatment decision. And to illustrate this concept of clinical judgment that I think often gets overlooked in prediction modeling, I want to work through a hypothetical example, and we'll have a few survey questions in just a second. In this hypothetical example, we have a 74-year-old ASA4 male who has carotid stenosis, severe COPD, stage 3 chronic kidney disease. They're undergoing a colectomy. And we take that data, we plug it into our prediction algorithm, post-induction hypotension, and we find that the probability that a patient will have post-induction hypotension is 98%. So extremely high chance this patient's going to have post-induction hypotension. Now, in this example, let's just assume the algorithm has essentially perfect accuracy, because there are still limitations, even in this case, which are important to consider. So if we believe that hypotension is bad, we need to do something in order to mitigate the effects of hypotension. And so for the sake of argument, let's just say that this ASA4 patient with carotid stenosis is at a 1% risk of having a stroke if we do nothing. They're at a 10% risk of having a pulmonary complication related to their COPD, and they're at 10% risk of having acute kidney injury given their baseline impaired renal function, which will come into play in a second. And so if we argue that this risk of a stroke or any of these complications is unacceptably high, we can take action. One action that we can take is we can give the patient a fluid bolus to raise their blood pressure, which is at the detriment of more fluid in the lungs. We increase the risk of a pulmonary complication, but to the benefit of the kidneys that have improved renal perfusion, reduced AKI risk. We also have a third option. Let's say we can give the patient a vasopressor, some phenylephrine or some norepinephrine. In this hypothetical example, let's just say that giving a vasopressor is equally effective for mitigating the risk of a stroke, and it doesn't pour fluid into the lungs or increase the risk of a pulmonary complication, but it does clamp down on renal vasculature and lead to impaired renal perfusion, and that leads to an increased risk of AKI. So, what's going on here? We have 3 choices, 3 consequences, clear trade-offs. And I just want to start with another Zoom poll here. And that is, what would you do in this situation? Assuming that these probabilities are correct. So let's not debate. Let's just assume that these are the accurate probabilities of these complications. And let's assume that you only have these 3 choices and that all other risks unrelated to these pulmonary, these three complications are equal. So just with those assumptions, what would you do in this situation? Would you do nothing? Would you give a fluid bolus, or would you give a vasopressor? So I'm watching the results, but I don't know if the audience can see them yet. We can.
Yeah, I'm going to stop it. I'm going to stop it in 5 seconds. I've knocked Tracy off of the controls, so you have a less agile person controlling things here now. That would be me.
There we go. So it looks like the fluid bolus is in the lead, followed by vasopressor, and there's There's one person that would do nothing. So it's interesting. We recognize that not all complications are equal, and we recognize that it's probably something to do with the trade-off between a pulmonary complication and acute kidney injury that we need to be thinking about. So I'm just going to stop sharing there. There we go. But we in this hypothetical example, we might recognize that not all complications are equal, and we may recognize a stroke is potentially way worse than a pulmonary complication or acute kidney injury, and so we need to make a judgment call. And we can't just add up these percentages, because we know that a stroke is worse, and we really care about that reduction in stroke risk. It's not enough to know that just a stroke is worse. We need to know exactly how much worse it is than a pulmonary complication or acute kidney injury, which leads me to the next Zoom survey question. I want you to ask yourself, how many acute kidney injuries or pulmonary complications would you be willing to tolerate to avoid one stroke? I think this is an interesting conversation that I think we don't often have as clinicians. But are we talking, and this can be on the order of magnitude. Maybe it's just a 1-to-1, maybe it's 10-to-1, maybe it's 100, maybe 1,000, maybe even 10,000 acute kidney injuries or pulmonary complications to prevent one stroke, or maybe you don't care at all about the acute kidney injury or pulmonary complication. You just want to solely focus on the stroke.
Though I'm sure that the AKI and or the pulmonary complication, should they occur, probably increase the likelihood of stroke down the line. But
Agreed.
We're talking about induction here.
Yep, I agree. So you do have to consider the chronic health recovery trajectory of these patients that have severe hypotension after induction. So we've seen the results. There's at least and I don't, what I would say is, I'm not surprised that we have a range of opinions here, and I would, again, I don't have any strong position here. I would push back on anyone that says there's an infinite number that they would tolerate, for maybe two reasons. One is, if from just kind of a healthcare economist perspective, if you infinitely value a stroke over the other complications, there's going to be some very unusual incentives for how you practice, and just simply preventing, if you're thinking about quality adjusted life years saved, which is often the way a healthcare economist might think, they would challenge you that you think that there's an infinite value of a patient's neurologic function compared to an acute injury or pulmonary complication. But the other thing I would push back on is this really the way that you practice in the OR? Do you solely focus on the risk of a stroke, and you are running this phenylephrine infusion at a very high dose on this patient, keeping their blood pressure very high, or are you practicing a different way? So I'll just offer those two. That food for thought for the folks that said an infinite number there. But I don't have an answer to this question. I think it's just an interesting, thought-provoking question. So with that, I'm going to go on to the next slide. These judgments that we're talking about, these are things as clinicians we do intuitively all the time, but we rarely explicitly codify these judgments into relative values, which is fine. We can rely on our experience and training to have a sense of what's important. But if we're really going to be precise about this and minimize the harm to this patient in a data-driven way, at some point we do need to make this decision about exactly how much worse a stroke is than a pulmonary complication or acute kidney injury. And when we do this, we're actually using a machine learning technique called reinforcement learning, in which an algorithm is reinforced by a good outcome, penalized by a bad outcome. And we develop this policy over time that makes a judgment about the relative burden of each bad outcome and decides on the course of action that minimizes the total badness to this patient. And so I'm just going to go with 100. This is a completely hypothetical example, but let's just say a stroke is, I guess, 50 times worse than a pulmonary complication. and 100 times worse than acute kidney injury. And this is totally debatable. And I encourage this debate since I don't actually think we often have it. But in this example, these are the values representing our judgment as a clinician. And at this point, and again, this is a simplified example. I recognize there's many other things we should be thinking about beyond these three complications. But if in this universe of problems that this patient could have, if we constrain it to these three complications, we do have an expected value problem where we can just multiply the burden of each outcome by the probability that it'll happen. We can add these up, and then lo and behold, we can see that giving a vasopressor was the best choice if these were our values. And so this patient, maybe we give some phenylephrine and maybe they have some acute kidney injury following the surgery, but they wake up neuro intact. And so taking a step back here, the really interesting part of this whole problem was not the probability of the hypotension, nor was it the probability of any of these complications, but rather it was the unspoken judgment, the clinician's intuition about the relative harms of each of these complications that was at the core of our clinical decision-making. So how do we get at this? Forgetting machine learning for a second, should we be having these kinds of conversations? And who should be involved? Should it be other clinicians in the healthcare system? Should the patient be involved? There's a level of complexity here that can get out of control very quickly, and it's a challenge that we need to be thinking about. So just going back to this figure showing the anatomy of a decision being made, and a medical decision, we're very good nowadays at analyzing data to make a machine learning derived prediction. Probability of hypotension in this patient is 98%. But we have a lot of progress to be made with analyzing the data for a prediction. A lot of progress to be made with quantifying the judgments for decision-making policies. This notion of exactly how much worse a stroke is than a pulmonary complication or acute kidney injury. And I don't actually have a great answer for how to navigate this issue. But what I can say is that even if we can't explicitly quantify our judgments, that might be okay. What we can do is we can actually reverse engineer a machine learning algorithm a machine learning algorithm can actually reverse engineer our judgment by predicting our actions rather than predicting the outcome. So if we just train an algorithm to predict what we would do, it can eventually learn our relative values between stroke, acute kidney injury, and pulmonary complications, rather than trying to predict the outcome. Just predict what we're going to do. Are we going to give the vasopressor in this situation, or the fluid bolus, or do nothing? And we can approach it that way. There's a huge caveat to that, obviously, which is that this will propagate our biases. If we have to decide, are we always right in our decision making? And if we acknowledge that we are humans and have biases, we have to grapple with this notion of a machine learning algorithm potentially learning those biases and reflecting them back at us. I just want to offer one high-profile example of this issue of bias in machine learning algorithms. There was a Amazon AI-based recruiting tool where it took a resume of a applicant to Amazon. It took everything written in that resume and it analyzed it with a machine learning algorithm. And it was trying to predict which candidates would be successful hires based on previous hires to Amazon. So looking at previous resumes. And when they dissected out what this algorithm was driven by, it learned that it was actually biased against women. So if you had anything in your resume that revealed that you were female, it ended up subtracting points from your recruiting score. And so for good reason, this algorithm was scrapped. It was absolutely flawed, but it did allow for some introspection of our own biases. I just want to highlight one. I'm nearing the end of this talk, but just speaking of bias, I do want to make one plug for a national initiative in our field, the RADAR initiative, which stands for Raising Anesthesiology Diversity Anti-Racism. Really seeks to challenge this unconscious bias that we all have and challenge the notion of what a successful anesthesiologist should look like. And so if you want to visit the website detailing the RADAR initiative with the QR code, you can, and we can join the discussion. On the website, I'll paraphrase the words of Dr. Megan Lane Fall at Penn, and Dr. Alice you may be familiar with, but she's an incredibly talented anesthesiologist, clinician, scientist at Penn, who, in regards to the RADAR initiative, points out that we can better see where we can go if we weren't so constrained by historical notions of what people are supposed to do.
I've known Megan since she was a senior medical student. I used to mentor her, and now she mentors me.
It's great. Yeah, I've learned a lot from her talks as well. But yeah, there's this issue of bias that we need to grapple with if we're going to use machine learning algorithms that are trained on what clinicians do rather than outcomes patients have. So just take home points. Machine learning for perioperative care is conceptually feasible. We have an FDA graded approach to regulating algorithms entering the market. We have things like the Epic Deterioration Index already embedded at the point of care for clinicians to use. The next steps really are up to clinicians to be aware of these limitations and use them to improve care and not allow them to incentivize misguided practices. So one final Zoom question, and then I'll leave you with one final slide of take-home points. Final Zoom poll question. If anything, where do you prefer to see AI implemented in anesthesiology? Is it in these high-risk scenarios that we talked about today, predicting sepsis or deterioration, post-induction hypotension? Or perhaps it's in more mundane things like improving your workflow, relieving you of medical documentation and administrative burden, or improving accessibility of healthcare to patients. So we'll do this quick poll, and then I'll have one final wrap-up slide.
While we're voting here, I want to thank everyone for joining us, and hopefully Michael can stick around for a few minutes for those who have questions, and if other folks have other things they need to do at the top of the hour, I thank you now for joining us.
Yeah, I see in the chat, yeah, your answer is a combination of all of these things. Yep. There's plenty of opportunities. I found that I've at least seen in the kind of hype phase of machine learning that we're drawn to the high risk problems, maybe not giving as much attention. My vote, if I were to vote in this one, would be actually just decreasing medical documentation, administrative burden. I think if we can figure out ways to generate discharge summaries on patients or progress notes in a more automated way, I think, yeah, I've seen some other comments in the chat. I think that would be one of, I think that would be met with some relief to clinicians and focus less on the high risk scenario. Okay, so anyhow, so we have a balance again. It's interesting to see, but balance across these things, so not one clear standout. All right, so with that, I just want to wrap up what we can do today, recognizing that machine learning is entering healthcare. I think one thing we can do is develop a literacy to machine learning and AI. And again, like I said earlier, just like any study in anesthesiology demands a basic literacy of statistics and study design, we can start learning a little bit about data science techniques, machine learning algorithms. And so we can develop this literacy over time. We should know the right problems for an algorithm to solve. So these are potentially low risk problems. So we don't want to maybe start with the highest risk problem where the FDA has very tight regulations to bringing that kind of algorithm to market. But a low risk problem where all of the data is available for making a prediction, and maybe there's not a high degree of outliers or nuanced clinical context that we need to consider. We should understand what's going into a prediction model, and just as importantly, what is not available for the prediction. So if you have a infinite amount of irrelevant, inaccurate, or biased data, even the most sophisticated machine learning model isn't going to work. We need to seek that transparency, that actionability. So just like we need to understand how a pulse ox works in order to understand whether we can trust and act on a low SpO2, we need to understand how a machine learning model works in order to understand whether a prediction can be trusted or whether acting on it would even make a difference at all. And then finally, we need to learn our biases before an AI or machine learning model mimicking our behavior makes decisions potentially reflecting back at us our own unconscious bias. So with that, I thank you. I really appreciate your time, and I'll open it for some questions now.
Thank you so much, Michael. So we have a question from the chat here from Reg asking, please comment on the use of AI to review articles and literature. I mean, because it's just exploding. Do you use it, and what AI tool do you think is best for this?
So you're talking about like generative AI for writing an article, or AI to
review? To review.
Yeah.
So you know,
Yeah.
to summarize. So there are these tools that can summarize a PDF
Yeah.
and, you know, give me the take home points.
Yeah, I mean, there's a tool right now that could summarize this meeting that we just had. It'll can use voice to text, you know, software, and then it can take that text and then summarize it through using a large language model. And yeah, I will raise my hand and say I'm far from an expert in doing this kind of thing. And what I have seen, I don't have any recommendation about which specific software or algorithm to use. There's a number of different you know, things that you can experiment with. I think on openai.org, I think there's you know, an ability to use a large language model. But what I will say is what I've seen, yeah. Yeah, if you're talking about the summarizing, that is generative AI. That's, you know, creating a document based on some input, which could be it could be the entire corpus of medical literature, or it could be, you know, a selected subset of articles that somebody doing a meta-analysis wants to feed into an algorithm. But it's going to be generative AI. And what I've heard from experts developing these generative AI technologies specifically tuned for healthcare is that the AI is good at summarizing, and it will effectively communicate clinical concepts. But there's a lot of work to be done right now on communicating uncertainty. So when an algorithm so when there's a lot of times in healthcare where the answer to a question is we don't actually know, you know, the right answer, but we can say with 80% certainty that this treatment may work for you. Like, and communicating that degree of uncertainty to a patient is something that a human clinician is actually reasonably good at, but a generative AI algorithm is not very good at. It's not it will make an assertion that is based on strong evidence versus weak evidence with equal conviction right now, and that's something that I know generative AI experts are working with in the medical literature to train algorithms to be vocal when they are uncertain, you know, about, you know, vocalizing their uncertainty around a specific clinical condition or treatment.
Well, we've got a number of people who thank you in the chat. I will say your kids are too young to be using ChatGPT for their homework, but I imagine that will come soon. My last question will be, can you make any comments about what happened with Sedasys? You know, the idea of, you know, having this closed loop monitoring, you know, BIS, blood pressure, propofol administration pulled off the market. Are we going to see that come back anytime soon, do you think?
I mean, I think eventually we are headed in that direction to, you know, anesthesiologists are very good at allocating scarce resources in a safe way and creating platforms. Again, you know, our model of running operating rooms and deploying teams to where, you know, you know, the right level of training to the right type of patient at the right time of day. We're very good at safely allocating scarce resource in a way, in a high risk setting and a safe way. Right now, I'm not sure we have the infrastructure set up for, you know, in the same way that we've thought about setting up ORs and ICUs. We haven't set up that infrastructure, I think, at least yet, for you know, monitoring algorithm performance over time, and knowing, you know, through a close-knit feedback loop, you know, frontline clinicians to that clinical algorithm governance committee that needs to be kind of done at a top-down level from hospital leadership. We need to organize that, and I think if as hospital leadership makes more strides setting up that infrastructure, I do think those kinds of things will be coming back, and you'll see it probably first at potentially, you know, hospitals that have set up this infrastructure. It might be a tertiary care academic medical center that tries to lead the way here and develop it, and then you get you know, that phase of early adopters and then fast followers, kind of the tipping point. I don't think it's going to happen overnight, but I think, yeah, as hospitals prove that this infrastructure can be set up, I don't know exactly how long it's going to take to get to that point, but I think there will be hospitals that are thinking in that way. U of M is one of many. I think you'll see that come back over time.
All righty. Well, unless anyone else has any question, I want to thank everyone for joining us. I want to thank Dr. Mathis for enlightening us this evening, and we hope to see you in Grand Cayman at some point in the future. Everyone here, and if you feel up to it, come on camera and wave goodbye. And if you're in your PJs, we understand that too.
Yeah,
I told Mike Mike has a 3-year-old. I thought that the 3-year-old might pop in the camera like that reporter in South Korea early in the pandemic, but no such luck. Oh well.
Yeah.
Thanks again. Thanks everybody.
I appreciate your time, everybody. Thanks for your attention. I appreciate the comments. Certainly email me if you have other follow-up questions. Happy to chat.
So yeah, we don't have your email right handy. Maybe we'll send out an email to everyone with his email, but he's at the University of Michigan. He's not hard to find. Michigan is number 2 in the country still in football.
Yes.
And you know, but you got to play Penn State.
That's true.
You got to play Ohio State.
True.
And Jim Harbaugh has to stay out of jail.
Yeah, that's true. Those things need to work to break our way for us to have a championship season. Yeah.
All right. Take care, everybody. Thanks again.
Take care.